Excellent. Good morning, everyone.
Morning.
Today is Tuesday, May 19th. The time is 10:06 a.m. We're convening the Board of Health of the New York City Department of Health and Mental Hygiene. I'm now going to conduct a roll call. Are the following members present? Dr. Angelo Akista.
Here.
Dr. Maida Galvez.
Here.
Dr. Sidney Hankerson.
Here.
Dr. Mitch Katz.
Here.
Dr. Simona Kwan.
Here.
Dr. Michael Lindsay.
Here.
And Miss Gail Nailwith. Absence is noted for the record. We have a packed agenda today where we're going to first start with a commissioner's update, and I'll introduce myself. Also going to share where the agency stands on a couple of key issues. We're going to then take up a Board of Health resolution on federal attacks on public health insurance coverage. Following that, we have several important health code amendments before us for consideration, and we'll close with an update to the board. Before I begin, though, I want to acknowledge that this board has not convened since November. We are in a transition period with a new administration and new leadership at this agency. Today's packed agenda reflects this board's commitment to getting back to work. This is my first meeting as commissioner and chair of this board, and I want to begin by sharing what drives me in this role. I'm an emergency physician. I spent my early childhood in Jackson Heights, Queens, a neighborhood of immigrants. And I myself am the son of one, a Haitian immigrant. My mother was a nurse. She worked in a program called Nurse Family Partnership, a program I now oversee. She would sit at kitchen tables with chipped laminate and help young immigrant women fill out applications in a language they could barely understand. She would rock newborns to sleep while she walked young mothers through the maze of healthcare, where a mother had to choose between taking a day off work that she couldn't afford or making a doctor's appointment. I watched her guide these women through systems that often seemed designed to fail the very people they were meant to serve. She taught me something simple back then, that when you are connected to someone's problems, you have a responsibility to help them solve them. That's the same principle that guided me as an ER doctor. I saw my patients' problems and I realized that solving them meant going far beyond the four walls of the emergency department. I spent my career building organizations and working on policy and government that help people access the coverage and benefits they're entitled to, because I've seen what happens when they can't. People delay care. They avoid the pharmacy. They show up in my emergency department with conditions that didn't have to become emergencies. This agency is connected to the people of New York. And as my mother taught me, when you are connected to someone's problems, you have a responsibility to help them solve them. That is the work of this board. But I want to be direct about the moment that we are in. There are also unprecedented attacks on the very foundations of the health coverage that keeps New Yorkers safe and healthy. HR 1 eliminated funding for New York's expanded essential program, a program that provided $0 premiums and $0 deductions to low-income New Yorkers. On July 1st, just 6 weeks from today, hundreds of thousands of New York City residents will lose that coverage. And they'll be pushed into a marketplace with plans where they could face premiums and deductibles that cost thousands of dollars. Beyond that, hundreds of thousands of New York City Medicaid enrollees are at risk of losing their coverage through new work requirements and biannual recertifications. Starting January 1st, 2027, Medicaid recipients will be required to document 8 hours a month of work activity or prove that they qualify for an exemption every single month. And they'll have to recertify their eligibility every 6 months instead of every 12. Make no mistake, these are not reforms. These are administrative obstacles designed to push people off their coverage. The evidence from every state that has tried work requirements tells us the same thing. The people who lose coverage are overwhelmingly people who were eligible for it, but just couldn't navigate the paperwork. These are blatant attacks designed to strip health coverage from our most vulnerable neighbors. And that leads us to our first action, the Board of Health, Medicaid, and Health Insurance Coverage Resolution. Here's what this resolution does. 3 things. Number 1, it condemns the broader assault on public health insurance coverage. This resolution puts New York City on record against the federal attacks on Medicaid eligibility and affordable insurance coverage, including work requirements in HR 1 and the failure to extend enhanced premium tax credits for marketplace consumers. The board finds these policies to be misguided, regressive, and unsupported by the evidence. Second, it directs the health department to build and carry out a Medicaid defense plan. The resolution requests that the department develop a comprehensive strategy, including public education, benefits enrollment, exemption documentation support, and care navigation in collaboration with other city agencies, state agencies, community-based organizations, healthcare providers, and managed care organizations, all in an effort to help New Yorkers maintain coverage or access affordable care in the event they lose it. Third, it commits the department to publicly tracking and reporting the impact. The resolution requests that the health department report publicly available data demonstrating the harms caused by these federal actions, including effects on health insurance coverage, access to care, and health equity. So the consequences for New Yorkers are documented, visible, and on the record. In the coming months, we intend to bring to this board a series of actions that use the full authority of the health code to protect New Yorkers' affordable access to affordable health care. I will not preview these actions today, but I want the public to know this board will not be a bystander. It will act. I'm gonna skip over these slides because there's a lot of words on them. But in essence, this is the language of the resolution, which we will make available. And so now we ask the Board of Health to vote to adopt a resolution condemning federal attacks on public health insurance coverage and requesting that the health department develop and carry out a plan to assist individuals at risk of losing Medicaid as a result of federal policy changes, including through public education, benefits enrollment, exemption, documentation support, and care navigation. May I have a motion to approve the Board of Health resolution?
Motion.
Second. Thank you. I'll now take a vote from each member. Dr. Maida Galvez.
Aye.
Dr. Mitch Katz.
Yes.
Dr. Michael Lindsay.
Yes.
Dr. Simona Kwan.
Yes.
And I'm voting aye. With a unanimous vote in favor of the resolution carries.
You forgot me.
Dr. Angelo.
Yes. So the question I have.
Yeah,
is,
so please.
how many people do we anticipate will lose coverage? Do we
Yeah.
have numbers?
It's a really good question. So let's first talk about the Medicaid HR 1 policy changes that will hit January 1st. So first of all, there are millions of individuals across the state who are going to be subject to these new exemptions and the biannual recertifications. And the state and our team have been working closely to figure out how can we essentially try and get as many of these individuals to be exempt without having to do direct outreach. This is known as a process called ex parte verification, where basically the state has access to data that could, exempt someone. So that's the first approach here, is to shrink the number as much as possible and to get that number to be as small as possible. If we do that right, perfectly. We're still looking, Dr. Kista, at over 500, about 500,000 people in this city that are going to have to, do these monthly requirements, and that are gonna have to basically struggle through that paperwork. And that's the population that we're trying to directly address. So 400 to 500,000 people in this city alone.
The other question I had is, you mentioned your mother helping
Yeah.
people filling out the applications. Who writes these applications? Is there a way we can contribute to make the applications simpler?
Thank you very much for that question. Yeah, so first of all, we at the health department have dozens and dozens of insurance enrollment specialists. These are known as certified application counselors. And they're the ones who are focused on helping an individual sort of navigate this process. Now, if the question is, can we make the application itself simpler? We don't control that. That's something the state does. And we're working with the state closely to figure out if that's possible. Folks might remember that about a decade ago, actually 2 decades ago, after 9/11, there was an emergency Medicaid application process that shrunk the application, dramatically to a couple of pages. It's no longer a couple of pages. It has grown. And so I think that there is some work that we can do with the state to help to make it more streamlined. What other questions are there?
Really looking forward to the work ahead. This is an important conversation.
Right. Well, with the unanimous vote in favor of the resolution carries, and we will move on to our next order of business. We're going to move on to approving the minutes from the November 13th, 2025 meeting. Are there any corrections that folks have to the minutes?
No.
Right. If there are no corrections, may I have a motion to approve the minutes as distributed?
Second.
I'll now take a vote from each member. Dr. Angelo Crista.
Approve.
Dr. Maida Galvez.
Approve.
Dr. Mitch Katz. Dr. Michael Lindsay. Approve. Dr. Sidney Hankerson.
Approve.
And I'll be voting approved as well. The minutes from the November 13th meeting are approved. And now we're going to move on to our next agenda item, which is the proposed notice of adoption amending Article 203 of the New York City Health Code and VR 18 form changes. Our presenter is Deputy Commissioner, Chief Epidemiologist and Deputy Commissioner for the Center for Population Health Data Science, Dr. Gretchen Van Wy. I'm going to turn it over to you.
Thank you very much, Commissioner. Thank you for having me. As the Commissioner mentioned, I'm here today to talk about the proposed amendments to Article 203 of the New York City Health Code, which we spoke about in November. As a recap, because it has been a while, we've been doing a number of changes, suggesting a number of changes to our abortion reporting here in the city over the past several years, post-DOTS. The city and the state passed legislation to protect patients seeking abortion care in 2022. In 2023 and 2024, we amended Article 203 and 205 of the code to increase confidentiality and make disposition optional. In 2023, the board also approved form changes to minimize information collected and to increase confidentiality. And then in 2024 and in 2025, we've really been doing a lot of outreach, listening to our providers, our reporters about their reporting of terminations of pregnancy. In addition, last year, the New York State Legislature changed its rules about reporting of induced termination of pregnancy. Specifically, the state public health law was amended to adopt the broader term pregnancy loss rather than the term fetal death. And it required the reporting of induced terminations of pregnancy only in instances where disposition was requested. Therefore, last November, on November 13th, we came to you, the board, to propose some changes to the health code. We wanted to clarify 20301's definition of terminations of pregnancy and spontaneous terminations of pregnancy to be consistent with state law. And we proposed to amend 20303 and 20305 to align with rest of state in terms of reporting induced terminations of pregnancy only in instances where disposition is requested. Since that time, we published the notice of intention in the city record in November, and we had a public hearing in December of last year. At that hearing, one person testified, and we received an additional 7 written comments. 7 of the 8 comments of the 8 comments were supportive. They noted the potential challenges to maintaining confidentiality of induced termination of pregnancy data and talked about the burden of doing such reporting. The 8th comment noted the loss of the data that has been provided for the reporting and planning public health purposes and was concerned about the loss of the data. However, they are overall very positive. Therefore, after consideration of the comments received, the department asks the board to adopt the amendments of the health code 203 as initially proposed. I'm happy to take any questions that you have.
This time, we're going to take questions from the board on amendments to health code 203. Are there any questions? Hearing none, we will now vote on the proposed health code amendment. May I have a motion to approve proposed notice of adoption to amend Article 203 of the New York City Health Code?
So moved.
Second?
Second.
Excellent. I'll now take a vote from each member. Dr. Sidney Hankerson.
Approved.
I'm voting approved. Dr. Michael Lindsay.
Approved.
Dr. Simona Kwan.
Approved.
Dr. Angelo Quista.
Approved.
Dr. Maidagalpas.
Approved.
Excellent. Given that we have a unanimous vote, we will vote to approve the motion, and the motion carries. Now, I'm going to turn it back to Dr. Gresham Van Wy to go over the changes to the VR18 form.
Thank you very much, Commissioner. In light of the recent amendment that was just approved by the Board of Health, the department proposes to amend the form actually used for this purpose. So this is a proposal that includes the concept of minimally necessary reporting to us. What you see right now is a copy of the current induced termination of pregnancy certificate, that's the VR18, and the areas that we're going to be talking about or that we're planning to address are highlighted. And there are a couple of changes that I wanted to walk you through. First, the title and instructions of the form would change. We want to change that from the certificate of induced termination of pregnancy to the report of induced termination of pregnancy. The second piece is to change the instructions to make it very clear that we want people to use this form only for induced terminations when a disposition is requested. We also propose to delete additional information from this form to comport with minimally necessary guidance. We propose to have people report only the items in the right-hand column of this table. That would include the date of procedure or when the medication was prescribed, the facility type, facility name, the facility address, and the eVital case ID, which is our unique identifier. This is what the proposed new form would look like. Much shorter, much simpler. Yes. And we ask the board to approve the form changes to VR18.
Less is more.
Yeah, excellent. We're going to take questions from the board on VR18. We'll now vote on the proposed VR18 form changes. Can I have a motion to propose this VR18 form change?
So moved.
Excellent. Second. Excellent. I'm now gonna take a vote from each member. Dr. Sydney Henderson. Approved. Dr. Maidal.
Approved.
I'm voting approved as well. Dr. Michael Lindsay. Approved. Dr. Simone Plum. Dr. Mitch Katz. Approved. With a unanimous vote in favor of the motion carries. Excellent. Our next item on the agenda is the proposed resolution to amend Article 205 and Article 207 of the New York City Health Code, which will also be presented by Dr. Gretchen Van Wy. I'm gonna hand it back over.
Thank you, Commissioner. This set of proposed amendments is about process improvement for the Bureau of Vital Statistics and serving customers better. As you know, the Bureau of Vital Statistics serves a crucial essential function for the city. We register 100 births every year. Our responsibility is to make sure we have 100,000 correct birth certificates for all those babies born in the city every year. And we're responsible for doing the same for deaths. We have 55,000 deaths from people dying in the city every year. These are used for lots of public health purposes and also official uses. People need these documents for obtaining passports, government assistance, driver's licenses. They need them for processing inheritances and making claims on estates. They also need them to prove their identity. These are the foundational identity documents that people have. And they benefit people and they're required to access benefits for all levels of society. And that's a really important part of our work, is to make sure people can get those for those purposes. We serve lots of people every year. In fact, between January of 2024 and December of 2025, we issued about 943,000 birth certificates, and we issued about a million death certificates and burial permits. So you notice that those numbers are much higher than the number of events that we actually see. We're actually responsible for maintaining about 15 million records. Those are all the births since 1910 and all the deaths since 1951. And people make requests to us to have copies of those birth certificates and those death certificates. We're the only place in the world where they can get them. So as people use these documents, they have changes that they need to make to them. And so we also every year receive requests for applications for corrections of birth certificates. We've got 69,000 of those over that period of time. We received 40,000 applications to amend or correct death certificates and 18,000 applications to correct or amend death certificates related to our medical examiner cases, which are of course those cases that require additional investigation. Those are external causes of death like drug overdoses or accidents, things like that. And as I mentioned, we seek continuous process improvement. When we're serving this many people, we're constantly learning about how we're doing, how we can do things better, and we're always trying to improve. Because a happy customer is a good customer for us. It makes everybody's lives easier. So we have noticed that certain vital records requirements have caused ongoing delay, confusion, frustration for both the public and the staff. And so we've conducted this thorough over a year-long review of our protocols and provisions related to our customer service in the health code. This deeper dive made it clear that we needed to propose targeted amendments to the health code, in addition to making procedural adjustments, changes in management, changes in our system that would improve customer service and better help us serve the customers. And so therefore, today I'm here to propose a series of amendments related to that review. This is a series of 9 changes. Some are very technical fixes to streamline processes. Some are to make our code consistent with current other legislative changes. One's intended to help the families whose loved one died traumatically. Another is intended to enable confidential amendment of death records to match gender identity. Again, all are intended to improve processes for the public and the department. The first change that I'd like to propose is to clarify access to birth certificates by individuals and families. So the gist of this is that the New York City Code says that parents can always get the same birth certificate of their child. They can always get access to that. It's not clear in the health code that that is true though. So it makes it unclear whether or not we should issue the certificate of birth to a parent once that child has turned 18. Therefore, we want to make the health code consistent with the administrative code and more clear that parents can always have access to their child's birth certificate. The second amendment is to make it more clear in terms of pre-adoption birth certificates. And so the issue here is that in 2020, the state law was changed to allow adopted persons to have access to their previously sealed original birth certificates. If the adoptee was deceased, their direct line descendants should have access as well. We've always complied with it, but it's not been clear in the health code that we should. Therefore, we propose a provision and an amendment to Article 207, 11K4 to have a specific right to access for adoptees and their descendants, as in New York State law. The third proposed amendment regards disposition and interim disposition. The issue here is that disposition and interim disposition are used throughout Article 205, but are never actually defined. And disposition is defined in New York State law as the care, disposal, transportation, burial, cremation, natural organic reduction, or embalming of the body of a deceased person and the associated measures. It's what our funeral directors handle. Interim disposition is understood to mean the non-final temporary relocation of the decedent prior to disposition. Funeral directors are currently able to apply for interim disposition permits without giving a reason for so doing. Currently, there's no time limit on between the issuance of an interim disposition permit and the final disposition. Therefore, a funeral director could theoretically hold on to a decedent for long periods of time without disposition. Therefore, we propose to add definitions and time limits. We propose to define disposition and interim disposition in 20501, and we propose to amend 20513B to create time limits for interim disposition of not to exceed 30 days. In extenuating circumstances, of course, a funeral director could apply for additional time for a date certain to a final disposition. And we would want to amend 20513A to require good cause for doing that. The fourth amendment that we propose is also related to death certificates. And the issue here is that the health code currently refers to New York State law about burial decisions to determine who may amend a certificate. So this allows an amendment by the individual who provided the personal information or the personal particulars about the decedent for purposes of the death certificate. This is the person listed as the informant on the New York City death certificate. These persons are not always related to the decedent, nor do they always have a valid interest in the estate or in the death benefits, and they don't have the same broad rights to amendment of death certificates that we see in the rest of New York State. The other piece of this is that alleged spouses can often request death certificate amendments to be added or to replace the spouse named. The reason is to make a claim on an estate or for estate for death benefits. So this requires the department to determine legal status of parties, meaning whether or not people were married, which is not really a great role for the health department to play. Frankly, this should be done by a court rather than an administrative agency. Therefore, what we propose is to amend to Article 20701A to remove the reference to New York State law on burials, to allow an informant 6 months to apply for a death certificate amendment, which goes along then with New York State law. We also propose to allow an amendment to a death certificate at any time by a close family member or by a representative of the estate, which is allowed in the rest of the state, and to require a court order to amend a decedent's marital status or domestic partnership, except by the medical examiner's office at any time or by a funeral director within 1 year of death. The fifth proposed amendment is to ease rules about who may change the personal particulars on the death certificate. So the issue that we identified here is that issuance of correct death certificates, which needs to be done in a timely fashion, can be delayed often due to the current rules about who can administratively amend the personal particulars section of this report. So that's date of birth, the name, but also other information that's important demographic information, and strict rules limiting our ability to change that and close to real time can really, by the healthcare facility, by funeral directors, can lead to delays for funerals and can then force families to have to request through a more formal process after the disposition has occurred to make changes. We'd like to make this easier in the entire initial process. So our proposal here is to amend the health code to streamline the process for administrative process for personal particulars. We'd like to allow healthcare providers to correct and to add information within 1 year of death. We'd like to clarify that the medical examiner can also always amend. We'd also like to allow designees of those healthcare professionals to do the changes. This is just more efficient for facilities. We've also proposed to allow designees of healthcare professionals reporting a death to amend certain non-medical fields of the confidential medical report of death and to certify personal particulars for purposes of issuing an interim disposition permit. Finally, we would propose to allow funeral directors to amend personal particulars without department approval if an interim disposition permit was issued, because that's sort of like a temporary holding permit before the final is created. The sixth amendment that we propose is responsive to the issue of not having clear language in the health code about making gender marker changes on death certificates. The department currently allows to make gender marker changes on death certificates, but it's not clearly specified in the code. Also, City Council recently adopted 17-166-1 to enshrine this important right into law. Therefore, we propose to amend Article 20705 to explicitly allow for sex designation amendments of death records, provide for issuance of a new death certificate in such cases, and seal those records. The seventh amendment that we propose is to allow issuance of OCME or medical examiner death certificates without the cause and manner listed on the face of those certificates. The issue here is that death certificates for cases investigated and reported by the medical examiner's office, which can include suicide, which can include homicide and other causes of death that are investigated, they currently list the cause and manner on the face of the certificate to allow for their use as prima facie evidence in court. Death certificates provided to families for other matters always include the sensitive information. Therefore, we propose to amend Health Code Section 20509B to allow specified family members to request death certificates without manner or cause of death when the case has been reported by the medical examiner. The eighth proposal is about 100% electronic reporting of death. So for over 20 years, we've had a law on the books that required electronic reporting of deaths. We have a really well-functioning system called eVital that receives reports of deaths in real time and has greatly sped up the process of reporting deaths and processing death certificates. The issue, though, is that there are still providers that the health code doesn't have a provision for providers that sign less than 10 death certificates every year. So what we would like to do is to ensure that everybody uses the eVital system to report deaths, even those who have fewer than 10 a year. Of course, in cases of emergency, we could always allow those to be issued on, reported on paper and issued that way. But we propose to amend Health Code 20503 to require all deaths to be reported electronically in the eVital system and to allow paper in emergencies. The ninth and final amendment that we would like to propose is just to delete the fees associated with spontaneous termination of pregnancy or pregnancy loss certificates. The state recently changed Public Health Law 4160A9 this year to prohibit charging for these types of certificates. We would like to delete the requirement that we have for payment of this fee so that we're consistent. We would like to propose that this occur in 20713A1 of the Health Code. Those are the amendments. I'm happy to take any questions. I know I went through a lot of detailed information.
Thank you very much, Dr. Van Wye. This time, we're going to take questions from the board. Amendments to Health Code, Articles 205 and 207.
I have a question. So the clarification regarding access to birth certificates by individuals and parents, can you just clarify what the challenge is there?
Sure.
Because I didn't quite follow.
Sure. So a parent can order their birth certificate for their child. Maybe the child's in college or away, has moved away, and it's easier for them to get the certificate than it is for the child. So they say, let me do that for you. And it's not been clear that we can. So we want to make sure it's very clear so everybody understands, team understands that it's clear in the law that that mom and dad, those two parents, parent one, parent two, they're able to order that certificate for that child.
I have a comment and then a question. First, I think starting with the report of induced termination of pregnancy. You've been just a wonderful fixture at our meetings
Thank you.
over the last several years. I think the process by which you have submitted these amendments really speaks to the level of community engagement of all key stakeholders that your division has undertaken. So I just want to elevate and applaud. So I guess my question about the birth certificate is, can you briefly describe the process by which you engage stakeholders on these 9 amendments?
Mhm.
And what?
Sure. So, you know, our customers are, for these amendments, our customers and the way we serve them are one of the most important things that we do. Every day we look at the orders that we have. They're organized into queues or lines of bodies of work. We review them. We see where there are hiccups. You know, we want everything to go smoothly, but there are always some things that don't go smoothly. And we catalog the reasons why we might reject an amendment, catalog confusion among our team, which can lead to missteps, you know, or slow issuance of certificates. So it's really by day after day, having hundreds of thousands of orders. We see about 100,000 people in person, but we have over 300,000 orders that come in online. So there's a lot of data to work with. We have dashboards that we use that map out our process, and we can see our bottlenecks. So we're extremely data driven. That's the only way to manage a process like this or processes like these. And so we're constantly in learning mode. So people give us feedback.
Thank you.
Excellent. Any other questions?
I just had a couple of clarifying questions as well, and thank you again for this really detailed approach to streamlining the whole process with clients. In proposed amendment number 5, do you have a definition of the designee of healthcare professionals?
Yes, we do. It's not provided here. It's different for the different events.
But it's clearly stated.
Yes, it's clearly stated, yes.
And then the other one was related to proposed amendment number 8. I'm assuming that all the providers have easy access to eVital.
Yes, also we have our constituent services unit, which is essentially like a little help desk for eVital, which works with providers. So if somebody says this death has occurred and they need to be enrolled in the system, we have somebody get on the phone with them and walk them through the process if they don't already have somebody who can help them.
Excellent. If there are no other questions, we will now vote on the proposed health code amendments. May I have a motion to approve the proposed resolution to amend Article 205 and Article 207 of the New York City Health Code, publication and comments?
So moved.
Second.
I'll now take a vote from each member. Dr. Sidney Hankerson.
Approve.
Dr. Maida Galvins.
Approved.
Voting approved as well. Michael Lindsay. Approved. Dr. Simona Kwan. Dr. Mitch Katz. Approved. Angelo. Approved. Excellent. With a unanimous vote in favor of the motion, the motion carries. Thank you very much. Our next item on the agenda is the proposed resolution to amend Article 173 of the New York City Health Code regarding lead contaminated dust. Our presenter is Andrew Faccione, Assistant Commissioner of the Homes Program and the Bureau of Chronic Disease Prevention.
Good morning, Commissioner. Good morning, Board. I'm joined here today by Emma Andrews. She is the Executive Director of the Healthy Homes Program. The work that we'll be describing today lives in the Healthy Homes Program. So we'll be talking about some proposed amendments that are aimed at continuing our progress to address and eliminate childhood lead exposure, and they will also bring us into alignment with some recently changed EPA rules. So as you know, most of you know, childhood lead exposure has been a problem for a long time, but it really didn't manifest itself broadly here in New York City until the turn of the century, where we saw the proliferation of the use of lead-based paint. Childhood lead exposure is especially important because at certain key points in a child's development, it can prevent key key parts of brain development. It can lead to damage to the brain and nervous system. It could lead to learning and behavior problems. And unfortunately, well, basically, most children do not exhibit symptoms related to lead exposure. And because children do not exhibit symptoms, we have universal testing requirements where all children have to be tested at age 1 and again at age 2. And that those reports are required to be reported to the Department of Health. And we use those data to identify children who require our follow-up and investigation. And so we know that lead-based paint and the related lead-contaminated dust continues to be an issue here in New York City because of the outcome of our investigations in the homes of these children. So New York City has been a leader in the battle to address childhood lead exposure, and we were one of the first jurisdictions to ban the interior use of lead-based paint in 1960. But unfortunately, by that time, more than 50% of housing was built that had lead-based paint. And ultimately, even though there's new development here in New York City, still the median year of housing is 1958. So many homes here within New York City have lead-based paint present under many layers of newer applied paint. And unfortunately, this lead-based paint, if becomes deteriorated, can lead to lead-contaminated dust. And so we're focusing here today on lead-contaminated dust because it is one of the most important exposure pathways for children, because as dust settles on floors and other components like windowsills, children touch these dusty surfaces and explore the world through age-appropriate hand-to-mouth activity, and that is the principal route of exposure. So in recognition of this route of exposure, we, as part of our investigations, collect dust samples to measure the amount of lead and dust, and if one or more of those samples are at or above the current thresholds here in the health code, we will issue what's called a commissioner's order for the property owner to clean the lead contaminated dust and then to take what we call clearance dust wipes. So they basically have to make sure that the levels of lead and dust that remain are lower than what we found there. It's pretty straightforward. If it's higher than this certain level, it's a hazard. Lower, then it's not a hazard. So that is how the health code is currently set up. But in October 2024, EPA actually amended the rules related to lead and dust. And for decades, they actually followed the same approach that we did. Had this levels at or above a certain level were a hazard, below was not a hazard. But now these new proposed rules that are now in effect require mitigation when there is any reportable level of lead on dust on floors or windowsills. And that's basically saying that anything that a lab can detect should be considered a hazard at that investigation part of of the workflow. Then in terms of the level for that has to be met after work is done, they cited our current New York City Health Code, which is codified at 5 micrograms per square foot for floors as an example. So these proposed changes introduce the disconnect where you can go into a home, you can collect dust and order at a certain level, but the cleanup, you can have higher levels than when you got there before. So this is really, it's very difficult to operationalize, very difficult to communicate to families, and led to a lot of different issues that we're trying to address with these amendments, but also being still consistent with these EPA rules. So what we're proposing to do is go back to a single definition. But we're going to use the term lead contaminated dust now. And so what we're going to set this threshold that applies for testing of floors and windowsills during our investigation. And then that same definition also applies for test clearance post-mitigation of floors, windowsills, and window wells, excuse me. And those are the 3 levels that you see, which represent a 20% reduction in the current threshold set by the health code. So by realigning these 2 different thresholds, we are creating levels that we know that laboratories will be able to achieve across the board here in New York City. Again, they're 20% below, so they are still more protective for children and families. So in order to make sure that laboratories can meet these lower thresholds, we are now requiring what's called NLAP accreditation, which is EPA's basically lead laboratory program. And they, in order to get that become accredited, you actually have to show that you can achieve results at these lower levels. So we're adding that. We currently only ELAB, which is the New York State's environmental lab approval program, was required under the health code. So in summary, we are proposing to change health code section 173.14E, and in part to delete the previous way we defined dust lead clearance, and we're creating a term lead contaminated dust, and we're using that term lead contaminated dust in health code 173.14B to update these levels. We're also then adding in that requirement to be both NLAP and ELAP certified laboratories. And we're also just cleaning up our definition of chewable surface, which was a little convoluted. We're not we're not introducing new requirements related to chewable surfaces. So we are asking the board to approve for publication and public comment the proposed amendments for Articles 173 of the Health Code, and I am happy to take any questions.
Excellent, thank you, Andrew. Are there any questions from the board?
As a pediatrician that calls upon you often for guidance, I really appreciate all of the efforts that you have taken and how you are truly leading the way for the nation in terms of preventing lead poisoning in children. So thank you.
Right, we'll now vote on proposed health code amendments. May I have a motion to approve the proposed resolution? So moved. Excellent. May I have a second? I'm now going to ask for a vote from each member. Dr. Sidney Hankerson.
Approve.
Dr. Mike Galvin.
Approve.
Voting approved. Dr. Michael Lindsay. Approved. Dr. Simona Kwan.
Approve.
Dr. Angelo Keaston.
Approved.
Excellent. Let's vote in favor of the motion. The motion carries.
Thank you.
Thank you very much. Our last item on the agenda today is a presentation to the Board of Health regarding the previously issued resolution declaring racism as a public health crisis. Our presenter is Dr. Zahira Knapp, Chief Equity Officer, Deputy Commissioner, Center for Health Equity and Community Wellness. Turn it over to you, Dr. Knapp.
Good morning, nice to see you all. Thank you so much for being here. I'm joined by my brilliant colleagues, Linnea Dubose, who's Executive Director in the Chief Executive Office, and also by Dr. Robert Rock, who is a Director in the Bureau of Bronx Neighborhood Health. So we're really delighted to be able to have this conversation today about racism as a public health crisis and provide an update on the declaration. Just to sort of situate us, we are representing the Office of the Chief Equity Officer and the Race to Justice Initiative that's been enacted in the Health Department for the last 10 years. This is a 10-person team serving the agency and focusing on internal equity infrastructure building. And so looking forward to today's conversation. This team is also the holder of reporting out on the Board of Health update, and we'll do that as the schedule allows throughout the course of each year. And finally, this team is not the holder of all of the implementation, and so you'll see lots of amazing equity work happening all across the agency in many divisions. As you may recall, in 2021, the Board of Health passed this resolution declaring racism as a public health crisis. There was a decent amount of attention to this and to a couple of other declarations across the nation. This declaration, as it states, declared the racism as a public health crisis and really helped the agency acknowledge a history of harm perpetuated by local government, ourselves, including other actors within the city, and the need for redress. And so it's specifically called on the New York City Health Department to take action through 7 requests. And we'll go through an update on all 7 in just a few minutes. But there are a variety of different and interesting areas here in relationship to truth and reconciliation, in relationship to data and data disaggregation. And so really thinking about all the ways that we could embed equity inside the health department and also within the health equity work that happens across the city. And so Linnea is going to walk you through the 7 areas and let you know how we're doing in each category.
Great, thank you, Dr. McNatt. So the first action requests that the New York City Health Department research, clarify, and acknowledge examples of its historic role in divesting and underinvesting, in critical community and health programs and participate in truth and reconciliation programming. So this has been completed. There have been a number of events, including the racial inequities in wealth and health evidence from a multi-ethnic survey. And we also want to point out the Lincoln Detox Center symposium, which our colleague will be giving you a deep dive spotlight on as well. So even though these are very long, I'm just going to spotlight 1 or 2 things from each of them. All right. The next one requests that the New York City Health Department establish a data for equity internal working group to ensure that the health department supplies intersectional anti-racism equity lens to public health data. And that is currently on track. The Data for Equity relaunched in 2024 and continues to do that work. They've made recommendations, and currently they're working on continuing development of guidances for better practice for collecting, analyzing, and reporting race and ethnicity data. The next action requests that the New York City Health Department makes recommendations on anti-racism, health-related NYC charter revisions to the Mayoral Racial Justice Commission, and that has been completed with 17 recommendations made. The next action requests that the New York City Health Department continue collaboration with sister agencies to report on fatalities, injuries, health conditions by race, gender, and other demographics. And that is currently on track. We recently completed analyses of the life expectancy and mortality among Black New Yorkers and are working on a report to publish that information later in the year. The next resolution action requests that the New York City Health Department, in consultation with relevant community organizations, perform anti-racial review of the New York City Health Code. This was established and operationalized in an equity analysis framework. And then the next action requests the New York City Health Department partner with NYC agencies and relevant organizations consistent with Local Law 174 to advise on assessment of structural racism within policies, plans, and budgets related to determinants of health. And that is also on track. The Coalition to End Racism in Clinical Algorithms was very successful and is also being applied on a state level as well. And then finally, the final resolution action is that there be updates to this Board of Health. And we look forward not only for having this update, but doing future ones to you in the future. Great, turn back over to Dr. McNatt. Oh, yeah. Or actually, sorry, turning it over. So right now in resolution action 1, we talked about our truth and reconciliation items. And so our colleague here is going to give a deep dive into the Lincoln Detox Center Symposium, which was one of those truth and reconciliation items.
Thank you so much.
Yes.
So just as a reminder, this was part of the first directive. So in 2022, we launched the Lincoln Detox Center Healing ARC project, where ARC stands for Acknowledgement, Redress, and Closure, to explore the history of community-led interventions in addressing substance use disorder in the South Bronx. We chose to focus on the Lincoln Detox Center in the South Bronx specifically due to ongoing inequities in both substance use, overdose deaths, and substance use treatment and support resource allocation in the South Bronx. The acknowledgement phase consisted of archival analysis as well as key informant interviews of 21 people directly connected to the Lincoln Detox Center or the Lincoln Recovery Center. And so during those interviews, we asked them 3 key questions. First was, what was the program like on the ground through the eyes of the staff, with clients, and community partners and administrators? The second question was, what was the cause and impact of its closure and the subsequent downsizing and later iterations to the community? And the last question was, given ongoing inequities and substance use outcomes, what should redress for these histories look like? So a triangulation of the interviews and the archival research identified the following history and key findings. So in November 10th, 1970, the Young Lords Party, the Black Panthers, and the community collectives of people who formerly used substances took over Lincoln Hospital for the second time that year and established the Lincoln Detox Center. The center was created in the context of a heroin epidemic and inequitable distribution of municipal resources for substance use in the South Bronx. Within the first year, the program was funded by the Addiction Services Agency with matching funds from Health and Hospitals Corporation to provide detox services, political education, auricular acupuncture, legal services, referrals to address the social determinants of health, peer counseling, as well as other holistic wraparound services. The program continued until November 1979, when it was shut down by the New York City mayor at the time, Edward Koch. The New York City Police Department barred community leaders of the program who were not H&H employees from entering the building. 12 staff affiliated with the Young Lords were reassigned or fired. And then the remaining staff were moved to a former health department building and continued the program under the name the Lincoln Recovery Center. The Lincoln Recovery Center continued from 1979 to 2011 at that same location. They actually grew the services that were initially created. They created a globally recognized training center for auricular acupuncture for detox, made available free of charge to community groups doing harm reduction in the area. During that time, acupuncture was actually expanded throughout the H&H network. They were the first substance use treatment program in the city for pregnant women. They hired a midwife to be on staff weekly. They developed counseling interventions addressing substance use and post-traumatic stress disorder from sexual trauma. And at their height, the LRC saw approximately 1,600 patients per month. In 2011, it was downsized. And that caused an abrupt move of clinical services to another site. Six of 35 substance use peer counselors were allowed to remain. The rest were reassigned. The maternal substance use program was ended, and the acupuncture training for the community was ended as well. Interview participants see the current overdose epidemic as a continuation of the heroin epidemic of the 1960s and 70s. In light of this, they named activities of redress that can heal past harms and prevent future suffering. There are 6 that I'll read to you now. It's public acknowledgement of this history. The second is investigating the long-term impact of the downsizing with a specific focus on the economic impact. The third was reparations for staff who were not able to collect pensions due to their firing or not being recognized as H&H staff. The fourth is development of comprehensive all-in-one substance use disorder treatment and support centers in the South Bronx in the spirit of the Lincoln Detox and Recovery Center. The fifth is expansion of acupuncture services, and that includes for pain as well. And the sixth is an expansion of mental health services. So in February 11th this year, we ended the acknowledgement phase and began the redress phase with a symposium and exhibition at Hostos Community College. The symposium featured panel discussions among former members of the Lincoln Detox Center and present-day leaders working in substance use treatment, support, and policy. We have submitted a manuscript of our evaluation for peer-reviewed publication. We're collaborating with an academic partner to publish an open access book. We are not resting at publications in terms of getting the word out. We are also bringing findings back to the community via a traveling exhibition telling the story of the LDC and this project. The exhibition is currently on display in the lobby of the Tremont Health Action Center. We are partnering with community organizations to display the exhibit at their sites. We are preparing a report detailing calls for redress to inform future work in health on substance use treatment service and support program. I'll pass it back to Dr. Mix.
Thank you so much for taking the time to listen to the update on the Board of Health resolution. We're really excited to be able to share kind of the progress in this work. This is generational work that takes place within city government across many institutions. And so we'll continue to provide updates on the 7 areas, and each time we come before you, share a deeper dive into one of the 7. And so thanks for sharing on the Lincoln Detox Center, and we'll pause for questions. Thanks so much.
Thank you for your update. I'm gonna turn it over to board here and see if there are any questions or comments.
I would just make a general comment that the issue of what is effective substance treatment program is as relevant today as it was then. And that, you know, part of the challenge of our efforts, and of course I resonate most with the part about trying to figure out a go forward. What is effective substance treatment program remains a highly debated and difficult to answer question. Right, I thought it's interesting. I mean, if you follow a strict scientific approach, you'd say acupuncture does not work for substance treatment. If you ask people who have had acupuncture, they will tell you that it has worked in helping them to stop using substances. It seems to me a lot of the field is like that. And that makes it difficult to figure out what is the most effective programming. I think that certainly for opioid use, the long-acting buprenorphine does seem to make a difference for some people. Again, nothing works for everybody. But it's certainly also a very incomplete treatment. Right? It doesn't address any of the other issues. It just decreases the level of craving people have. So I think, to me, the most important thing, and thinking about the South Bronx, is what would, based on both the interviews, the history, the science data, what would it say what would the most effective substance treatment program look like in the South Bronx? I feel like if we could get a little further on what the ideal program would look like, we would know better how to build it.
Thank you.
I just want to thank you all for this update. It's very timely, especially at this complex time. This was actually my first vote as a board member, so I'm very appreciative of all the hard work you've been, the progress that's been made, and being able to hear the updates. So thank you.
Thank you for your vote.
Any questions?
My only question is, when are you coming to other boroughs? Such impactful work, I think. Combination of kind of the qualitative data, quantitative outcomes, I think, powerful. And I do want to echo complexity factor that's elevated around substance use. Just thank you.
With that, thank you very, very much for this update, you all. And thank you everyone for your service. The meeting is now adjourned.
Thank you.
Thanks, you. Well done.
Good night.